And so we will record this meeting for those who cannot attend in the live virtual portion. Hi, Priya. But without further ado, I will pass this off to Denise M. Robinson, our president and CEO. Denise, thank you for being here today. Let me get the screen share going.
Good afternoon, everyone.
Good afternoon.
Hello.
Good to see you all. This is one of my favorite times.
And Denise will be going over our mission, our agency timeline, and the lines of service. So Denise, you can get started.
Okay, thank you. So I'm not gonna spend a lot of time, but about 15 minutes with you all, and I appreciate it. I really like talking about our mission and our vision. And our mission, and you'll see this if you've looked at our website or other materials that we have. Our mission is to innovate and deliver evidence-based human service programs that empower those we serve to build successful, productive lives. Our vision is of a future when communities believe that a person's potential is more important than their past. A mission statement, as you probably know, is a very high-level overview of what we do. And a vision statement is what we hope to achieve. The Alvis vision statement is broad, and it includes that what we really want the community as a whole to believe. And we want the community as a whole to believe that a person's potential is more important than their past. In other words, you know, let's not just keep dwelling on their past, but let's look about their future and their potential for the future. That's why we need everyone working, volunteering, and interning for Alvis so that you all can be ambassadors about the importance and value of turning lives around. Next slide. So I'm going to go over the Alvis timeline, and it's basically a history. And then in decade one, I'm going to go through them pretty quickly, though. So I'm going to move through the 5 decades Alvis has been providing services. There is additional detail on our website, again, if you are interested. In the beginning, the new agency that we took the name of Alvis House in honor of the late Ralph W. Alvis, who had been a progressive warden at the Ohio Penitentiary. So ironically, Ralph W. Alvis had passed away before we were able to open our doors. Alvis's specialized employment services for individuals with justice involvement were groundbreaking when they opened in 1977. And then Alvis first began serving individuals with developmental disabilities in 1981. Next slide. So decade 3, when Alvis, that's when we first began serving women. They only had a section in one of our facilities that was our main offices, but we also, you know, the agency was traditionally a male-oriented organization, and then we started taking women. Today, women are the fastest growing segment of the correctional population, and we're very proud of the incredible breadth and depth of gender-specific treatment we offer here at Alvis. Next slide. Decade 4. And you can read those on the screen if you want to, and then if you want this information, the slides, you can get them. In this decade, it saw Alvis's expansion to Chillicothe and Toledo, and the beginning of Ohio Link Corrections and Treatment. And then the Veterans Residential Program, it opened on the grounds of the VA Medical Center in Chillicothe in 1997. Today, it's a larger program in the Terry Collins Reentry Center, or TCRC. We have so many acronyms, and you probably won't even learn them all while you're with us because it's just so many. But TCRC is really unique, and it houses Alvis, the Adult Parole Authority, and the Sheriff's Department in one facility. All provide some form of reentry services designed to reduce the risk that individuals will return to the criminal justice system. There's a picture here, and that is the ribbon cutting at Alum Creek in 2000, and that's in Columbus. Now we are building a larger addition to Alum Creek, and we will be breaking ground on that facility in June. And then once the new facility is open in 2020, we will renovate the current Alum Creek building so that we can house all of our community corrections programs for women in Columbus. So it's going to be really a lot going on. And next slide. So in decade 5, had so much going on. This decade was one of expansion at an extraordinary pace to meet emerging needs of our clients. Chat, which is changing habits, attitudes, and thoughts, open, funded by the Atom, and is a program for women who have become involved in human trafficking. So then there's another organization called Community Connection for Ohio Offenders. It became part of Alvis. So community corrections was done through an asset acquisition. We also opened a residential program in Lima, and then the Terry Collins Center, which I mentioned before, in Chillicothe opened. And then the Family and Children's Program it was a brand new service line for Alvis, as is Recovery Choices also. And that is an outpatient substance abuse treatment services. And that brought the agency to 5 lines of services. And next slide. So in decade 6, which started in 2017, this has been the decade marked by expansion in behavioral health care treatment services, Page's Treatment and Recovery Center, which is on Livingston Avenue here in Columbus, Amethyst, which was another nonprofit organization, and it was a women's treatment program. It became part of Alvis. And then Alvis expands Recovery Choices, and that the name of our behavioral health care services into every geographic area in which we serve. And so that's been really, really a value add to the organization. We also opened 2 recovery housing programs for women. One is called Shine, and it provides 6 to 12 months of transitional housing. It is open to both women with or without children, just like Amethyst. Then the other one is called Belmar, and it's for women without children. We plan to open a recovery housing program for men by the end of this year. So we're busy trying to put that together because men deserve recovery housing just like our women. Next slide. Who does Alvis serve? So individuals and families, vulnerable and underserved populations with justice involvement, persons with developmental disabilities, and behavioral health care treatment needs, people who need Alvis to reach their potential. So what our clients have in common, though, is across all of our lines of service: stress from having few resources, emotional, financial, social, mental health issues, trauma-related issues, substance use and addiction issues, challenging behaviors as well as poor social skills. Our clients have barriers to employment, housing, rebuilding families, and education, and that's what we do best. Stigmas from having justice involvement, substance use disorder, mental health disorders, and their families are also stigmatized. And so it's just really something that I'm very proud of, and I feel like people that work here are very proud that we're able to meet the needs. By having all of those service lines, we're able to meet the needs of every client that comes through our doors. And I think the next slide is mine too. Is that correct, James?
Yes. Mm-hmm.
Okay. Okay. And this continues with who do we serve? And it's just broken out into community corrections, workforce development, developmental disability, integrated behavioral health care, family and children's program. In the timeline, you can see where each service line came to be part of what we do at Alvis. So again, if you get some time, take a look at that timeline. We've expanded the types of services we offer in order to provide a continuity of care for individuals and families. That statement, continuity of care, is something that I live and breathe by. I believe that everyone that walks through our doors should have some type of continuity of care, whether they're coming out of prison, come to us, then go into one of our recovery houses or go into their own homes. We have to continue to care for people along the way. We've expanded the types of services we offer in order to provide that same thing for families. And then also, Alvis, we're committed to providing holistic services that make people and families whole. And where are we located? You can get that too off of this chart. So you can see in community corrections in Columbus, we're on Bryden Road. We have 3 facilities: Alum Creek, Jackson Pike, Long Street, Chillicothe. These are all community corrections: Chillicothe, Lima, and Toledo. Workforce development is here in Columbus too, in 2 places: Reentry Center and Reeve Avenue Center. And then developmental disability services, they are all over Franklin and Licking County. Then our integrated behavioral health care line is Amethyst, which is here on Mound Street. And then Recovery Choices here in Columbus is at Page's Treatment and Recovery Center. And then we also do it, like I said earlier, in Chillicothe, Lima, and Toledo. And then our family and children's program is here is on Bryden Road and with Amethyst. This slide just breaks down where each of those lines of service is located. It is not listed on the slide yet, but we have begun expanding family and children's services to men, and we're starting at Alum Creek Drive. So you will see that. Is the next slide mine too?
Yeah, this all ties in, I think, to
Okay.
like the service. So yeah.
Okay, so behavioral health services meeting the need. Much of Alvis's recent expansion, it's been in the behavioral health care services. What we find is that so many people that are in prisons and jail, and you can see that on the slide, 20% of those incarcerated have serious mental illness. 30 to 60% of those with mental illness have substance abuse problems. And then we always look at statistics. Our organization, actually, we do programs based on the outcomes of any research that comes out. So we follow the data, we follow the science. Across the country, individuals with severe mental illness are 3 times more likely to be in jail or prison than in a mental health facility. And then 40% of individuals with severe mental illness will spend time in jail, prison, or community corrections. The intersection of justice involvement with substance use disorders and mental health disorders just cannot be overstated, because it's like one big system. There's so many people in the justice system who need treatment, not punishment, just to get better. And then next slide. We are making an impact. Recidivism, you'll hear that, is defined as a conviction and return to a criminal justice system or a serious post-release violation that results in a person being returned to custody. I prefer to say that 79% of individuals who complete the Alvis residential community corrections programs do not return to the justice system. And that is measured over 3 years after completion of our programs. And what's important about that is the national average is about 50%. And so Alvis is way above the national average. Their recidivism rate is about 50%. In Ohio, the recidivism rate is about 30%. And at Alvis, our recidivism rate is 21%. So as you can see, I'm smiling because it's good to be at an agency that really takes seriously how do we work with our clients. Next slide. So COVID-19 measures. We have been probably, I would say, ahead of the game in most instances. Prior to COVID, we had a crisis plan that we always follow. And part of that crisis plan included a pandemic. And because of that, we were prepared for the pandemic. We already had PPE, we were prepared, we had our stockpiles. What we weren't prepared for, however, is that it would last so long. So some of the things, if you come into our facilities, you will see temperatures are taken at the front desk. Everyone has to still wear a mask at all times. Excuse me, seeing clients in person, we were trying to cut down on all those kinds of visits. Virtual and remote options are available. Group supervisions, we utilize Zoom and Teams and WebEx. The state of Ohio, as you know, is eliminating all COVID health orders effective June 2nd. Alvis is not. We will continue to follow best healthcare practices in all of our programs and facilities and to adjust practices as needed. to maintain a safe environment in a congregate care setting. What you have to understand is if one person gets sick, say in our Chillicothe program, if one person contracts COVID, it has the potential to infect over 200 people. We just cannot stop doing what we've done to keep people safe and healthy throughout this pandemic. We are encouraging, we're not mandating that everyone who interacts with our clients and our staff gets vaccinated, but we are strongly, like I said, strongly encouraging people to get vaccinated. It is extremely important. And we've been doing a lot of outreach to a lot of our staff and clients to ensure that they are vaccinated. So that was my last slide, and I am here for questions and answers if you have any.
Does anybody have any questions for Denise?
Are you serious? Was I that complete?
You were very thorough and complete. So thank you so much, Denise. I had one question I'd just like to ask because I think it's insightful for everybody here, but that why Alvis question, you've been our leader for so many years, and before that you were with Alvis for even longer. So for everyone here, if you could just express what keeps you coming back to Alvis, and why Alvis at the end of the day.
Yeah, I've been at Alvis for 36 years. And so I started when I was 12, and we, I kind of grew up in the agency. No one laughed at that. You were supposed to laugh and say, there's no way you could have been 12 years old. But anyway, why Alvis? That's a very good question. I enjoy seeing the fruits of our labor. I enjoy seeing people come through our programs and get well, and their families get well. And my mother has a motto, and I kind of taken it on myself, that if you help one, that one will help two, that two will help four. And she would say, and so on and so on. And I think it's really, really important that we keep that in our head all the time, is that if we walk away from our jobs and your internships and your volunteer duties, if you help one person, you have done an amazing job, because that person's going to help somebody else. So it's really important to me. I got goosebumps because I love talking about the staff in our organization. When I started, we were a small agency with 60 staff people. We have almost 500 staff now, and we're in about 35, 37 locations around the state. So we just have to maintain that we're going to help someone every day. And you have your hand up. Pronounce your name, Mahisha?
Maisha.
Maisha? Mm-hmm.
Mm-hmm. Oh, I have a question. Like, when a gentleman graduates the program or whatever, like, and they need to come back, like, how many times do y'all accept them coming back?
You mean it like they messed up or they relapsed or something like that?
Yeah.
So, all of our programs are based on assessments. And so we do those assessments. So in some cases, the referring agency, like the Department of Rehabilitation and Corrections or the Federal Bureau of Prisons, sometimes they allow them to come back, sometimes they don't. So it's all individualized, every program, and you'll see that when you work with whichever population you're going to be working with. It's very individualized, and the assessments actually dictate how, and the assessments and the referral source actually dictates how many times they can come through the program. Mm-hmm. Any other questions? Well, I see Sarah's arrived, and I know she's after me. So good luck to you all. And I can't wait to see you at the end of your semester. And it's going to be fun. I'm excited for you all, because you will see something when you go to our facilities and work with whoever you're working with. You'll love the organization. I can tell you that, or I wouldn't have been here 36 years. So have a good afternoon, and I'm going to jump off. Bye,
Thank
everyone.
Okay.
You're welcome.
Thank you,
You're
Denise.
welcome, Priya.
Okay, great. Well, I will pass it off now to our next speaker, who is Sarah Gwynn. Many of you have probably met Sarah during the background check process or corresponded with her so far. But if you have not, this is Sarah Gwynn, and she is our HR compliance specialist. So I will start the screen share now. Thank you for being here, Sarah.
Yeah, of course. I hope you guys weren't waiting for me. In true HR fashion, things popped up.
No problem.
Fires to
I
put
think
out.
it's perfectly timed. Yeah. But Sarah will be presenting on human resources and Alvis culture. So the floor is yours, Sarah.
Hi, everyone. Like James said, my name is Sarah Gwynn. I'm the HR compliance specialist. I actually started as an intern, so I was in your shoes about 3.5 years ago. I was an intern with the HR department here at Alvis. And then when my internship ended and when I graduated, I came on full time as a compliance specialist, and I've been here since. So like James said, also, I'm just going to be going over like human resources type things and like Alvis culture as a whole. A lot of this stuff will kind of be a refresher on like the policies and stuff that you guys reviewed and signed off on with like your internship paperwork and stuff. So yeah. So first up, we have kind of just general overview of the structure of Alvis. So at the very top, we have our board of trustees, and then reporting into the board of trustees is Denise Robinson, our president and CEO, who you just heard from. And then we have our executives who report into Denise. So we have Linda Janes, who's our chief operating officer. She's over the corrections programs, DD services, workforce development, intake, behavioral health, Amethyst, chat, recovery choices, and the family program. So basically all of our programming that we offer at Alvis, Linda is over. And then we have David Middlecamp, who's our chief financial officer. And so he's over our business office, IT, and facilities and maintenance. And then we have our vice president of support services, Ramona Wheeler, and she is over our support services. So we have HR, training, continuous quality improvement, risk management, and then also PRIA, which I believe Ramona will be speaking to you all a little bit later about PRIA. She's our PRIA coordinator for the organization. And then we also have resource development reports into Denise. So all of our like marketing and communications and stuff like that. And then we also have accreditation and QA. Jennifer Storrs, the director of accreditation and QA, and the quality assurance team report into Denise directly as well. So that's just like a high level overview of how Alvis is organized. So first thing, dress code. We have pretty standard business casual dress code. Since COVID, so for the past like year, we've actually relaxed our dress code. So instead of jean being permitted Friday, Saturday, and Sunday, we've actually had it all week just because we aren't having outside visitors, and it's pretty much just Alvis employees and clients in all of our facilities. So a little bit of a relaxed dress code, which is nice right now. So on the next slide, just kind of some examples, you know, nice pants, nothing with like holes. Ladies, if you're going to wear leggings, that's totally fine. Just be sure that you're wearing a top that's long enough to cover your rear end. Any jeans with like distressing or like athletic clothes or anything like that would not be allowed. Even during jean day, it would have to be like plain jeans, nothing crazy on them, no holes or anything like that. Shirts, just appropriate shirts, nothing too form-fitting or too revealing. No like tank tops, spaghetti straps, stuff like that. Next one, just some more. So like with footwear, the biggest thing with your shoes, obviously shoes that are like in good condition. no like sneakers or like flip-flops or anything like that. You can wear sandals. Well, okay, I should say you can only wear sandals if you're not in one of the facilities. So if you're going to be in one of the facilities, you have to wear closed-toed shoes at all times. That is an OSHA requirement. So just like a health and safety thing. So if you're in any of the facilities, just be sure you're wearing closed-toed shoes. And those could be loafers or dress shoes or like flats, boots, anything like that. No hats or sunglasses like inside, unless it's for religious purposes or anything like that. And just professional appearance at all times is what we ask. And I sent, James should be sending out, if he hasn't already, a copy of the dress code, code of ethics and rules of conduct for everyone, just to kind of have on hand. I even have mine hanging up behind me. I think they're super helpful to just have on you at all times. So you guys should all be getting your own copy of those.
Yes, I will send those out after the orientation. Thank you, Sarah.
So social media, just be sure and just keep in mind, be wary of mixing your personal and professional lives on social media. Anything that you do in reference to Alvis as, you know, your employer, like internship, place of volunteering, should, you know, be respectful and in line with our mission and vision and our values. We also encourage that you guys interact with us on our social media. So we've got LinkedIn, Instagram, Facebook, YouTube, Pinterest, Twitter, and Vimeo. Follow us, tag us if you're posting stuff about like events or anything like that. Engage in our posts. If you have any suggestions on like things that you think would be a great like social media post or campaign or something like that, feel free to reach out to Priscilla Teixeira. She's our marketing and creative director. But the main thing with social media is just to be sure that everything is respectful and professional. Equipment, I don't know how many of you will actually receive your own equipment, but if you do, just keep in mind that it is Alvis property. The expectation is that you are exercising care and caution at all times. That might include computers, phones, key fobs, actual physical keys, anything like that. And then you may be held responsible for any damages or anything like that. So just, you know, treat Alvis property with respect and caution. So confidentiality is going to be a huge thing with Alvis on the client side of things. So under no circumstances should you be disclosing any client information like name or anything like that, or identifying them as an Alvis client outside of the agency unless there's an active release of information signed by the client. And you should always consult with the staff member first. Client information like that is protected under HIPAA. So it's really important that we're keeping clients' information confidential and not, you know, putting any of their information at risk. As far as employees and like management and like business information, the disclosure of any sensitive employee management information can lead to loss of employee trust and confidence. So it's really important that anything that you learn or are made aware of, you're not sharing. And failure to properly secure and protect our confidential business information can lead to the loss of business and clients. So it's really important, like I said, that nothing's being shared that isn't authorized to be shared. The exception to the rule for this is anything to do if a client is threatening harm to themselves or others. And if that happens, if a client discloses that to you, you are required to immediately notify Alvis staff, and they will follow response procedures regarding that sort of thing. I think Dr. Shively will talk to you guys about like risk kind of stuff. So the only type of client information that is not covered and is required to be reported is any threatening of harm, because it's really important that that does get reported so it can be addressed so that no harm comes to fruition. So non-discrimination and harassment/bullying. Alvis is committed to providing a workplace that is free from discrimination and harassment, including sexual harassment and bullying. Any concerns that you have, please report them immediately. We take all concerns very seriously, and we will maintain confidentiality to the fullest extent possible while we investigate anything. So some examples include like rumors, gossip, or innuendo that are not true, belittling somebody's opinions, criticizing a person. Those are some examples of like harassment. So if there's anything, if you see anything or if something happens to you, we encourage you to report it immediately to your supervisor so that it can be addressed. And then along those same lines, so workplace violence prevention, like I said, where Alvis is committed to providing a safe workplace, and that also includes being free from violence. So once again, if you have any concerns for violence or your safety, please contact your supervisor or HR immediately. Even threatened violence should be taken seriously and should be reported. Another kind of side note thing, if you have a restraining order in effect, we ask that you notify your supervisor and HR immediately, because that would be something that we would like to be aware of, just so that we can accommodate and be aware of it if, God forbid, something were to happen. Okay, and then code of ethics. So our code of ethics just kind of details, kind of outlines some things that are not acceptable as an intern or volunteer with Alvis or employee. Just inappropriate behavior and unethical behavior. So that includes exchanging personal gifts or favors with Alvis clients or families or friends, endangering client, staff, or community through intent or neglect, misuse of company funds or assets, subjecting clients to any form of physical or mental abuse, financial exploitation or any other exploitation, withholding information that threatens the security of the facility, its staff, clients, visitors, and or community. And like I said, James will be sending out the full list of code of ethics. And we expect that everyone is conducting themselves ethically and demonstrating honesty, fairness, and integrity while, in service of Alvis. And then the rules of conduct kind of just go alongside the code of ethics. So some more examples of behavior that is not allowed or unacceptable would be sleeping on duty, disruptive or insubordinate behavior, smoking on company premises outside of the designated smoking areas, and then violation of like drug and alcohol policy. I think that's it. So another big thing is professional boundaries. So it is your responsibility to respect others and their rights. We expect, we ask that you don't handle personal business or interests while at work or overshare personal details or information with clients. That can kind of blur that line between staff and client, unprofessional, like friendship level boundary that we shouldn't be. We're not friends with our clients. We are there to help them, of course, and encourage their, treatment and recovery, but we're not their friends. So, keeping inappropriate language out of the workplace, not gossiping, maintaining that professional relationship with clients, and not keeping secrets. So, and then also like not doing something for one that you wouldn't do for others. So, not picking favorites or showing favoritism for any of the clients or anything like that, or coworkers even. Alrighty, so I know that was a lot. Does anybody have any questions?
Any questions for Sarah? Well, thank you so much, Sarah, for presenting today. And like Sarah was saying, we have some documents related to her segment of the presentation that will be emailed to you after this orientation. So you will have those for your viewing as well. But thank you, Sarah, for being here. I know you also had to get going soon after this. So I'm happy that we had you for this portion of the presentation.
Of course, of course. It was good to see everyone again.
Thank you.
Bye.
Thank you.
Thank you. Bye.
And I see that Dr. Shively has also joined the call. Hello, Dr. Shively.
Hi, how are you?
Doing well. Thank you for joining us today. So I'm going to go back into screen share mode. And this next portion of the segment will be on suicide and homicide prevention and intervention. And this is Dr. Shively. He's our Director of Research and Clinical Development at Alvis. So Dr. Shively, the floor is yours.
Okay, thanks. Well, welcome everyone. I have been a staff person at Alvis for about 28 years. So I've made this my career. I have a private practice. I'm a psychologist in the state of Ohio. I love what I do. I have, for Alvis, worked a lot with the American Correctional Association on a lot of different treatment teams. One of them is behavioral health. So a lot of what we'll be discussing in this presentation has to do with behavioral health. So next slide. So suicide statistics. I think probably all of you know about homicide because you see things on the news every day when somebody's killed or hurt in our community. But what you're probably not aware of is how common suicide and suicide threats are, especially in the field of corrections. So in the general population, there's about 650,000 people yearly that receive emergency treatment due to attempts towards suicide. And it's quite a few. I think probably if we got new statistics, I bet throughout COVID, the numbers have gone way up, would be my guess. People have been pretty desperate, and suicide, unfortunately, is an option at times for desperate people. The next statistic, I bet most of you do not know, that over the last 100 years, suicides outnumbered homicides 3-2. And you might ask yourself, why? How could that be? Because you probably don't hear much about suicides. Well, it's because the media often avoids talking about it, and families do not like to talk about it. It's kind of a taboo subject. But we've got to have open dialogue about this topic if we want to see suicide numbers go down. Families feel a lot of shame around this topic. They often underreport what's occurred. And I have learned in my practice that there's a window of opportunity. When somebody's suicidal, you may have hours to days to deal with where they're at, or it can be a bad outcome. If you get them help within that window of opportunity, you can often save a life. Firearms account for over half the completed suicides. And usually the firearms are used when intoxicated. So suicides often happen when somebody's under the influence of drugs or alcohol. And fortunately, many suicides can be prevented if we give somebody help or somebody speaks up in the family before things get to a tragic end. In corrections facilities, hanging is the most common method of attempted suicide. I knock on wood because I've been at Alvis 28 years and we've never had a successful completer of suicide. We have had some overdose deaths. So you might say, well, maybe they were trying to kill themselves. and that's unknown, but we've never had a hanging that I know of in any of our facilities, which is a good thing. We have a suicide policy that I'll be talking about a little bit later, and I think that has saved some lives over the years. Suicide and homicide share common ground. I don't know if you knew that. When somebody is suicidal, they're probably homicidal and vice versa. What's shared is crisis. People do crazy things when they're feeling crisis upon them. And suicide and homicide both have to do with anger. In the case of suicide, anger is turned inward towards the person. They're usually very frustrated and angry with their life and usually very depressed, and they'll take their anger out on themselves. Homicide, it's just the opposite. They put the anger outwards towards someone else, but they're usually very angry also at life. So suicide and homicide share common ground, and we've got to be aware of that to protect the person and to protect the community. Now, depression is highly linked with suicide, and depression is a disease of the brain. There's an imbalance when somebody's depressed, and that's why antidepressants work with depression, because they restore balance to the brain. Depression will not go away any quicker than heart disease. If it's not treated, the person can die. Just by some hands, how many people have known somebody seriously depressed in their life? Raise your hand. Yeah, probably everybody's hand's gone up. Very common. And when somebody's in the throes of a depressive episode, their chance of completing suicide go up. That's why within the window of opportunity I discussed earlier, we got to get the person help. So if somebody's highly depressed, a question you might want to ask them is, are you thinking of hurting yourself? And if they answer yes, then the next question is, how do you plan on doing it? The more plans somebody has, the more risk of suicide. If they don't have an organized plan, their risk of killing themselves goes way down. But you always want to ask those questions if somebody's in the throes of depression. Now, it's important, the second point, it is not when the person is highly depressed is when they're going to kill themselves. I don't know if you know the answer to that, why they don't. And the answer is usually because they don't have the energy. When you're highly depressed, you're usually very tired, like a limp rag. You don't have the energy to take your life. But when you're coming out of your depression and feel better, if the suicidal thoughts are still there, that's when somebody's going to complete suicide. So just because somebody feels better does not mean they're out of the woods. You always need to ask, are you still thinking of hurting yourself? And if they are, we've got to, within that window of opportunity, get them help. Now, what are the symptoms of major depression? Let's go through those. I always use the abbreviation SIG-ECAPS. So the first letter of each of these characteristics represents one major depressive symptom. So the first is sleep, the S. Somebody sleeps more than usual or less than usual, that could be a symptom of major depression. If I normally get 7 hours of sleep a night and all of a sudden I'm getting 11 or 12, or just the opposite, I'm not sleeping at all, or maybe 1 or 2 hours a night, that could be a symptom. Second, interests. Something that usually excites somebody and brings enjoyment no longer does. I usually love to be outside doing sports, but I haven't done that in months because I sleep all the time. I'm unhappy. That could be a symptom of depression. G, guilt. Somebody that's majorly guilty. They feel guilty. Everything's their fault. They may feel guilty about feeling guilty, but all of a sudden they feel guilt-ridden. That could be a symptom of major depression. People that are depressed are very hard on themselves. E, energy. Somebody that's majorly depressed will report feeling like a limp rag. They have no energy. They drag throughout the day. Some depressed people say, I feel like I've got a pound of weight on my back and I'm carrying it through the day. C, concentration. Somebody that's majorly depressed will report having trouble focusing. They may not be able to pay attention for any length of time. And all these I'm bringing up are abrupt changes. They haven't been there in the past, or at least not to this degree. A, appetite. Somebody that eats much more than usual or less than usual could be a symptom of depression. In other words, I start snacking on everything. My appetite just goes crazy, or just the opposite. I have no appetite at all and I don't eat for days on a time. P, psychomotor, or you can just put down motor skills. When somebody's majorly depressed, their motor skills slow way down. They start talking slowly, and usually their volume goes way down. And then finally, suicidal thinking. Somebody that's majorly depressed usually has some suicidal thought. And once again, you got to ask, do you have a plan? Do you have a plan to hurt yourself? So homicide and suicide trends. I mentioned this, but 50% of homicide and suicide completers or offenders are under the influence of alcohol at the time of the crime, and heavier drinking more is present in homicide offenders. So substances cloud the mind. Substances create impulsive behaviors, and substances impair judgment when somebody's under stress. So you often will hear that somebody's been intoxicated or under the influence when the incident occurred. So don't forget, this is really important. We train our staff they have like a 3-hour suicide and homicide training, and we train them to worry about the client's safety always first. There is a lot of paperwork you have to fill out when somebody's in crisis, but that can be filled out later. We can't go back and save a life. We can go back and fill in the blanks. So we always got to have our focus on the client, get them to safety, get them help while they're in that window of crisis. So Alvis House policy and procedure, we're not going to go through it, but I'll give you the 3 major steps that staff learn. The first step is always err on the side of caution when putting somebody on a suicide or homicide status. And our first step is to get them sent to emergency services. This would usually be in a hospital or a clinic. But we want the professionals to evaluate our clients. We don't want all the liability on us. So the first step is to send somebody when they're in distress or in crisis to emergency services. 90% of the time, emergency services send the client back to us at Alvis. And when they get back to us, we'll put an action plan in place. What is an action plan? It's a 2-page document that Alvis creates, and it individualizes how we're going to keep the person safe as long as they're on this status. And what are the triggers we got to watch out for that could create a bad situation? So we will try to keep the person safe with this action plan when they return to us from emergency services, from the hospital. And then the final step, we get a clinician involved if they're in corrections, or it's called a behavior support person if they're in DD, developmental disabilities. And this person monitors the case and makes the decision when to take somebody off a suicide or homicide status. They usually have a questionnaire they ask the client, and they monitor the situation closely, because the worst thing to do is take somebody off before they're ready. If I take a client off a suicide status and they're not ready, that's when they may kill themselves. So we're very conservative and careful as an organization in deciding when to take somebody off. When they're off the suicide or homicide status, they go back to regular status in the facility with all the same privileges they had before the status. But we're really vigilant on this because we want to protect the client and not have any needless consequences of homicide or suicide. And as I say at Alvis, we've been very fortunate over the years. I think it's because we've trained our staff so well to be careful and follow these 3 steps. So that kind of completes my portion on suicide homicide. What kind of questions do you guys have about depression or about homicide or suicide as it relates to corrections?
Does anybody have any questions for Dr. Shively?
Nothing you wonder about? Or about suicide in the general population?
I have a question.
Uh-huh.
Like how common is it for clients in the facility to be on a status? Like, do you
Great
see it a
question.
lot or not really?
Not real common. How we usually average across all our facilities, and we have, boy, I don't know the number, but I'm sure it's probably close, and on any given day, 300 to 400 clients in all our facilities. We usually average about 1 to 2 people on suicide or clients on suicide status a quarter.
Okay.
You might have 1 a month, let's
Okay.
say. So it's not super common. However, when you do have a client like that, you got to act quick and know what to do, because they're in this window and it can be only a couple hours if you don't get them help. And with the drugs available in the facilities, I could try to take my own life by just an overdose.
Mhm.
Yeah,
Thank you.
great question. Anyone else?
I know you talked a lot more, I guess, in regards to like adults into those situations for corrections, but I do know that there are services for children as well. Are there procedures in place for the kids that you all serve? And is it different? And I only ask specifically because that's kind of the department that I'll be interning under with the family and children. So I didn't know if that procedure looked a little bit different than what the folks in corrections would proceed with.
Yeah, great question. Yes, it would be very different because the corrections folks we serve live with us. So they're with us 24/7, where the children come in with their parents for services. And it might be on maybe, I don't know how often they get together, but maybe 1 or 2 hours a month. So, and they're usually going to have staff and clients with them. So they don't really have those kind of opportunities, the kids. But that's a great question. And then if they did come in and were suicidal, which I don't think's happened, but if that would happen, we would send them emergency services in the community immediately. We'd call 911 and get them there. A very good question. Anyone else? How many here, I'm curious, how many have known somebody that's suicidal? Usually, okay, that's about right. It's usually about half to 2/3 hands go up. Not that uncommon. It could be somebody in your family. It could be a friend. Realize there's resources in the community. I think it's one of the numbers is 1-800-SUICIDE. So you could write that down. You could give to somebody, and I think they have crisis services, through the phone 24 hours a day. You can always call emergency services. Somebody will come right out. But the thing you do want to do is get the person help. If you think there's a possibility, I would rather jeopardize a friendship than have a friend end up taking their life. So you always want to get somebody help if you know they're in crisis and they're thinking about possibly taking their life or someone else's. Any other questions? Okay. Well, it's very nice meeting you guys as a group, and good luck in your internships. I hope it's real positive for all of you. But there's a lot to learn here at Alvis.
Thank you so much, Dr. Shively. That was a very insightful presentation.
Okay, thank you
We'll
very
be
much.
seeing you at the end of the term as well.
Okay, take care.
Yeah.
Thank you.
Thank you.
Alrighty, everyone. So now we will go into our final portion of the presentation. I have Ramona Wheeler on the call with me. Hello, Ramona.
Good afternoon.
Good to see you. And so Ramona will be presenting on our PREA portion of the presentation. PREA stands for Prison Rape Elimination Act, and Ramona Wheeler is the Vice President of Support Services here at Alvis. And Ramona, I know you sometimes like to make the PREA portion interactive, so I can change the speaker view at any time. If you want to see hands raised or anything like that, just let me know. But otherwise, I will be clicking through, and the floor is yours.
Great, thanks, James. So again, my name is Ramona Wheeler. Good afternoon, everybody, and thank you for being here. This portion of your orientation is to talk about the Prison Rape Elimination Act, or PREA as we call it for short. And to give you a little bit of background about this, it's a federal law that pertains to any and all correctional facilities in the country. So it started in 2003 under President George W. Bush. And then the standards became effective in 2012 under President Obama and Attorney General Eric Holder at that time. So essentially, the law requires now for all correctional facilities to demonstrate how we keep our residents or inmates sexually safe. So that's what we're going to talk about today. So what we're gonna go over today is just to make sure you have a general understanding of the PREA standards and the requirements as it relates to your role as interns, our zero tolerance policy, some of the dynamics of sexual abuse or harassment in confinement settings such as Alvis, how to respond to an incident if you become aware of something, and to help identify your reporting requirements specific to sexual abuse or sexual harassment of our residents. So what you're seeing here is an actual standard. And so they all start with the 115 point something. So 115.231 is what indicates that and requires that everyone who interacts or engages with our resident population, that they receive training on the agency's policies related to resident sexual abuse or sexual harassment. There's also a National PREA Resource Center, and they provide all kinds of training information and is an awesome resource if anyone may be women's studies major or something of that nature where you might have need to write papers or do research on this type of behavior. Particularly in correctional environments, the PREA Resource Center is a great resource for information. So when we talk about zero tolerance, it's not the same as someone was late one too many times and you get a write-up of some sort or some type of counseling. When we say zero tolerance, it means that if we substantiate sexual misconduct by a staff, for example, it means that they are not permitted to work in our facilities anymore. If it's another resident who's found to have conducted themselves in a sexually inappropriate manner, it could mean that they are removed from our program or potentially could even face new charges. When the standards talk about staff, it doesn't just mean Alvis employees. It means also volunteers, which includes the majority of our students, as well as contractors who do business with Alvis in our program. So say a doctor or a counselor who isn't on Alvis's payroll, but maybe a contracted person to come in and facilitate. So because they still have access to our residents, they still fall under PREA standards. So the first thing you want to know is if you suspect something or become aware of something, who do you call? So there is a 24-hour hotline number that is available for both staff and clients, and you see it here in red. So you'll also see this number in facilities, on posters and flyers, so that we make sure our residents are aware of who they can contact if they want to report something. We have a client management system called Secure Manage, and there is a dedicated report form in that tool. And there's also a hard copy version that can be completed and filled out in our shared drive known as the Z drive. So if you are a first responder, which we'll get into in just a minute, you will be required to document what you know or suspect on that PREA report form. And so section A, easy to remember. The first section of that document is for the first responder to document what has occurred. And that's what you would access on the Z drive. So when we talk about PREA standards, there's three primary elements that falls under these standards. So the first one is sexual harassment, which is non-physical behavior. And when we're talking about residents, it's the repeated and unwelcome sexual advances or comments or offensive jokes even falls under this. So the repeated and unwelcome element is what makes the behavior rise to harassing behavior. However, if a staff member is involved, it doesn't matter if the behavior is repeated or if it's welcome. So if I were to say something, of a sexual nature to, say, a male resident, he might like what I said, but that doesn't make it any less inappropriate. So it's important for us to know that even when our residents may say things or do things, if we reciprocate, even get kind of lured into their banter, it can end up buying us an allegation of sexual harassment. So it's very important to understand it doesn't matter whether they welcome or willingly participate in the behavior, they are still considered as a victim. Sexual abuse is when there's physical, sexual touching or activity that occurs. So it doesn't have to be actual sex, but touching in areas that are considered sexualized. So you see here, it's explicitly identifies those areas, but it could be other areas if the intent is sexual gratification. So we want to be clear that if a resident takes offense or says they're uncomfortable because someone is touching them, rubbing their back, for example, it doesn't matter that your back is not listed here. If it appears or if the perception for that client is that the person who is rubbing them on their back is doing it for a sexual satisfaction, it still could be considered sexual abuse. if a client and a staff person were to become personally involved, so let's say an actual relationship develops and that relationship becomes sexual, again, that resident is still considered a victim because there is an imbalance of power between us and our residents. So there's no such thing as consensual relationships or consensual sex. Retaliation is when the person feels that they're being punished somehow for reporting that something has occurred or that they've cooperated during an investigation. So if they feel like, if it's an employee, for example, maybe they didn't get the promotion that they were lined up for, right? Or maybe their shift gets changed to a shift that the supervisor knows that employee can't work. And none of these things were happening until that employee reported an allegation of sexual abuse. Then that employee could allege that they are being retaliated against. Retaliation, if you see here on this slide, it says a client or staff who's being punished in some way. So it's the one element that does not only apply to our residents, that also includes staff. So this is our protection from somehow suffering a negative repercussion for essentially doing the right thing. Some of the dynamics of sexual abuse and harassment in confinement settings. So what we're talking about here is the difference between some type of sexual misconduct that may occur in the community versus in a correctional residential facility, whether that's a prison or jail or a halfway house such as Alvis facilities. So we have to remember that in this environment, that again, clients don't have the ability to consent to sex while they're in our program. And again, that's not just with employees, but also volunteers or contractors. And it's because of that imbalance of power that exists. So understand that even though you may consider yourself just an intern, you still naturally in our correctional environment have an inherent authority over our resident population. So if you were to hit on somebody or want to be involved with a resident, it's that imbalance of power that creates a victim with that client. Even if that client is the one who's coming on to you and hitting on you, and I'll talk about how we control their behavior, but when you reciprocate, there you've created a victim, okay? Clients oftentimes see relationships with staff in particular as the only way to get things that they want or need, or to even repay a debt with another client. So bartering and borrowing amongst themselves can sometimes lead to sexual activity occurring because they don't have the money to pay back. So there's other ways that they can pay it back. So that is not considered consensual and should be reported. Any questions so far? Okay. So when we're talking about female residents in our program, many of the ladies in our program have already been traumatized and victimized in unhealthy relationships or even have experienced past sexual abuse. So they frankly are accustomed to using their bodies as currency. And so it's not uncommon for women in our program to offer sex in return for something that they want. But again, if we as staff um, basically take them on with their offer, then we've created a victim, even though that resident is offering to do something of a sexual nature. Women are much more at risk for unhealthy relationships based on their perception of someone's authority or perceived power. So there's sometimes like a family dynamic that occurs in facilities, and someone may hesitate to report being sexually harassed or sexually abused because they don't want to disrupt that dynamic. They don't want to be considered an outcast. So they may, suffer in silence. And so it's important that we keep our eyes and ears open to those kinds of dynamics so that we can address them. And, coming from prison, oftentimes, as our clients do, they're used to very invasive processes. So even though we do things like pat searches in facilities, it is nothing like what they do in a prison or jail, where they may actually be strip searched or have cavity searches. We don't do that. And so, but because of them being used to not having privacy, oftentimes their sense of boundaries are way off for our environment. So they may, continue to replicate sexual behaviors because it's what they're used to dealing with. And so it's our place to keep them encouraged that, this is not the environment they're in anymore. And they do have certain rights to privacy and self-care. And so it's important to try to understand why some women in our programs do some of the things that they do. So first responders, who is a first responder? So the short answer is anyone. Anyone who sees something, suspects something, is told about something first. So whoever knows about or learns about a situation first is hence then the first responder. And clients have multiple ways that they could report some type of sexual misconduct allegation. We have a grievance process that they can utilize. So there's an actual grievance form that they could complete and submit. They can verbally report to any staff. They could report it to you guys. So you would never want to say, oh, no, you don't want to tell me that I'm just an intern here. I'm not an actual Alvis employee. They absolutely can report it to you. And you want to receive that information because we want to keep in mind that every time we ask them to repeat their story, they are living it again. So we could be re-traumatizing someone by taking them to different people saying, okay, tell this person what you told me. They're reliving that experience and being re-traumatized. So if they tell you first, you want to know enough of who to contact and what to document. So that's very important that we don't re-traumatize our residents if they are reporting sexual harassment or sexual abuse. They could also be reporting it from an experience while they were incarcerated. So PREA applies to any correctional facility at any time, even a juvenile facility. So someone might share a horror story that something they experienced when they were a teenager in a juvenile institution. That still needs to be reported, okay? There is no statute of limitations on reporting sexual abuse, particularly an adult from an adult institution, because as we know, there are people in prison who are never coming out. So this is why there's no statute of limitations, because we want to have the opportunity and give those potential victims the opportunity, once they're out, the ability to identify those perpetrators so that we can stop, hence the E in PREA, the elimination component, eliminate further abuse, sexual abuse of other inmates or residents. Again, you could witness something. If you see someone making sexualized jokes at a client or calling them names, again, that's sexual harassment, and you might witness that and you should report it. Other residents might witness the behavior. So if there's roommates in a facility and one could report that two others are, another is harassing or attempting to abuse another inmate in the room. So a client can also be a witness and report. A third party could also report an allegation. So a third party could be a relative who maybe has visited or communicated with our resident, and the resident has said, ooh, this situation is going on, and maybe that our resident doesn't want to be involved or doesn't want to report. They could tell an outside person, and that person can report as well. You have the ability to also report an allegation privately. So privately means, and you wouldn't necessarily call me directly on my Alvis line. You would call me on the hotline, right? Or you could call me outside of the time that you're in our facility or program. So you have the right to reach out and report something privately as well. So we want to remember again who's involved when a situation is brought to our attention. So if it's a staff and a client, then we have to remember that the client is always the victim. Even if it looks like the client is a willing participant with the staff, they are still a victim because of that imbalance of power that we talked about before. If it's a situation that involves clients only, then we want to make sure that what we're hearing about is non-consensual. So sometimes clients meet and hook up and they like each other, they get involved. So that doesn't break the rules unless it crosses the boundary of sexual behavior. Sex is not permitted in our facilities. So, but at the same time, we want to be sure whether that is consensual or non-consensual. If it's consensual and it's two clients that like each other, if we find that they are engaging in sexual conduct in our program, that's a program violation for them, okay? But if someone is an unwilling participant, is essentially a victim, then it's a PREA-related issue. So when you're reporting something, we want to make sure that we capture as much detail as possible. So how many people are we talking about in this situation? Is it because you could have multiple victims in a situation, you could have multiple abusers in a situation. So you want to get as much detail as possible. So if a client were to tell you they're being sexually harassed, for example, by another client, you want to ask the question like, do you know if this person is harassing other clients? Okay, so that we get a feel for who and how many people may be involved in a situation. You want to also make sure that we document that information on the PREA report form, and that you notify me as the agency PREA coordinator or the facility PREA compliance manager. So every correctional halfway house facility has an established PREA compliance manager that typically is either the operations manager or the facility director. So you can always reach out to me no matter what. And if the situation is something that I would want you to communicate with the facility PREA compliance manager, I'll make sure you know who that person is. When we're documenting a situation, we want to make sure that we don't forget about who the alleged abuser or harassing individual is. Because if it's someone who lives in that same facility, for example, we want to make sure that we are also taking steps to keep that alleged victim away from the alleged harassing individual or abusive person. So make sure that when you're gathering information or documenting what was told to you, that you keep in mind who they are identifying, if they identify the alleged perpetrator, because we want to take immediate steps to separate the victim from the abuser if they're in that facility. So again, when you are documenting, it's not rocket science. We want you to just be as accurate and explicit as possible with the information that you know. So when did they say something happened? If they know the date. Sometimes though, people who have been sexually traumatized may not remember the day. Okay, and it does. So if you ask them, well, when did this happen? If they don't remember, it seems foggy, don't assume that it's because they're not telling the truth. Okay, because it could actually be a sign that they have been traumatized. And there's other ways then that we want to try to jog their memory. So you might ask, well, do you remember, let's say it's someone who has a job. So did you work that day? Had you had dinner that day? So that way we're trying to establish, did this happen at night or did it happen during the day? So sometimes asking questions about time and space perspective. Had you showered? Do you normally shower before you go to bed? So did this happen after you were showered or before you got in the shower? So these kinds of things help us with a timeline, which is very important because we have tons of cameras all over our facilities that record for up to 30 days before it starts to override. And so, to try to sift through footage and we have no idea whether we're talking a day ago, a week ago, whatever, it would be virtually impossible. So it's very important to try to establish a time frame of when something may have occurred and the location if it's known, particularly in the facility, because that guides us on what video footage we might be able to retrieve. Any other known details are also important to gather because things like maybe the alleged victim and perpetrator work at the same place. That's an important detail to document. So we want to make sure to capture as much information that we can so we can take the necessary steps to keep the alleged victim safe and know what to do with that alleged abuser. So as a first responder, one of the things when you're reporting, you want to try to identify with the reporting individual if what they're telling you was an isolated incident versus something that is been happening over time. So again, our DVRs may hold up to 30 days worth of footage. So if something has happened more than once, then that's important to know so that we know to look for different days worth of footage for potential evidence. So when we investigate an allegation, there's two types of investigations that can occur. There's administrative and criminal investigations. At Alvis, we do not conduct criminal investigations. Our investigations are administrative and basically establish that PREA standards have been violated, as well as any other applicable Alvis policy and procedure. During that investigative process, if it involves a staff, for example, or even a volunteer or contractor, you would be not permitted to be in our programs while the investigation is underway. So for paid employees, for example, it's a paid administrative leave. So we're not punishing the person because someone has made an allegation. They are paid, they're on the clock, they're expected to be available at any time based on their normal work schedule during the course of the investigation. Because our goal is to determine that if the allegation is not true, then we want to get you back in the programs, get our employees back to work as quickly as possible. In Ohio, there is state statute that also talks about sexual abuse, sexual misconduct in correctional facilities. And so Alvis is still considered a community corrections environment in our halfway house programs. So if someone were found to have been sexually involved with a resident, again, even if that resident was a willing participant, you could be prosecuted, and if you're convicted, it's a third-degree felony in the state of Ohio. So is it ever worth it? No. At the end of the investigation, there's three potential outcomes. So if we find that we have enough information and evidence that we know what was alleged is true, then that investigation will be substantiated. That means staff could be disciplined up to and including being terminated, and face possible prosecution. As I said earlier, clients could also face violations and sanctions, being terminated from the program, or potential new charges being filed against them. If we don't have enough evidence to truly substantiate the allegation, it likely will be tagged as unsubstantiated. That doesn't mean that we don't believe what the victim said. It only means that we don't have enough information or evidence to truly say it's been substantiated. So that is common in allegations related to sexual harassment, for example, because unless there was a witness, it's usually one person's word against the other. And so therefore, unless we have a reason to completely disbelieve what the client is saying, then typically they get tagged oftentimes as unsubstantiated. Even if it's unsubstantiated, it doesn't mean that our hands are tied to take administrative action. So employees have still been disciplined or even terminated for unsubstantiated allegations. Why? Because maybe it's the third time we've heard that person's name, or that we've heard a similar story by a different client about the same staff. So how many times do we have to hear something before we recognize that there's an issue going on, that just maybe that staff person is a little savvy and knows how to cover their tracks? If we feel like there's a pattern that we can support, then disciplinary action, including termination, may still be an outcome for an unsubstantiated allegation. If we know what the alleged victim said is not true and what they allege did not occur, then we will tag it as unfounded. Unfounded is very different from unsubstantiated. Unfounded means you didn't tell the truth, and we know you didn't tell the truth. And if it's related to a client, another client, that person who's reporting could again have violations, including being terminated from our program for making an allegation in bad faith. So even if we can't substantiate an allegation, there's no repercussion towards the reporting client if we feel like they made a truthful or a valid allegation or report. If we know it's untrue and we know their intent was in bad faith, so to get another client in trouble or to get a staff person in trouble, then they could be terminated from our program. So as a first responder, there are some things that we don't want people to do. So we don't want people to interview the victim or the alleged abusive person, because again, we could be re-traumatizing people because we're not trained to deal with those kinds of situations. So you don't want to interview them, but it's okay to ask questions, particularly, like I said earlier, if we're trying to put things in a time and space perspective. So that's not interviewing. Interviewing is, well, where were you on this day? And why do you think this person did this to you? And did you know this person? So when you're asking more probing questions, then we want to stay away from that and leave that to the people who are trained to deal with trauma and trauma-informed care. We don't want to try to collect any evidence ourselves. So again, if there's an allegation of physical sexual abuse, then we will bring law enforcement into the situation, and they will conduct any kind of forensic collection of evidence. We don't do that because, again, we're not trained in that regard, and we could contaminate evidence if we don't know what we're doing. We don't want to report just verbally. So even though a resident can report verbally, as I said earlier, is one of the ways that they can report an allegation. When we're the ones who are the first responder, you can't call me and say, oh, Miss Ramona, I want you to know about something somebody told me, but the people involved, like, this is really serious and I don't want anything to do with this. So I'm going to tell you, and then that's it. We have to document. We are required to document what is reported to us. So I'm going to direct you to the PREA report form and ask you to document what you've told me. So that is required. It's not required that your name be involved. So again, when I talked about reporting privately, you can also report confidentially. And so we will talk through the scenario, and I will always be transparent to let you know if or when your name would have to be disclosed. Otherwise, you do have the ability to report confidentially. We don't want to allow the alleged victim or the abuser, okay, if we're talking about a physical sexual abuse allegation, to do anything that could contaminate evidence. So if the alleged abuse happened within the past 4 days from when it's reported, there could still be physical evidence that could be collected. And so we want to make sure that, if they still have the clothes, even the underwear that they wore, if they're not washed them, we don't want them to. We don't want them to eat or drink or brush their teeth or go to the bathroom if there has been sexual contact within the past 4 days. So we want to make sure that we involve people so that we can determine if there's physical evidence to be collected. Again, we also never want to forget to separate the alleged victim from the abuser. Any questions? Okay. So when we identify that someone has unfortunately experienced sexual abuse, if they need medical attention, we want to make sure that we involve our victim support person. So again, that's another role that people play in our as the victim support person with her and help that client exam. So you want to make sure to know who that individual is in the facility where you work. We want to make sure that someone offers to accompany the alleged victim for any kind of medical services, or if we refer them to a community-based resource. So for example, let's say a client tells you about a past sexual abuse that they are still struggling with, and you know an organization in the community that deals with rape victims or sexual abuse. It's fine for you to refer a client to those resources. Just make sure when you complete your reporting that you document where you may have provided information to that client for services. One of the things to keep in mind is that if mental health or medical services are rendered in the community, so if the person, say, goes to the hospital and they go through a forensic exam, there's never a charge to the victim for any medical services that they may receive. So if someone were to tell you about an experience, but is hesitant about being checked out by a medical professional, then you want to remind them or let them know that they don't have to pay for those services. So lack of financial resources is never a reason that someone shouldn't seek medical assistance. So here, we talk a little bit about some of the timelines that are associated with investigating allegations. So when a client uses the grievance process to report an allegation, we only have 48 hours to get back with that person. So it's important that you understand that, so that you forward that report to me or to your facility PREA compliance manager immediately, because as soon as something is reported, that clock is ticking. Now, it doesn't mean that we have to complete our investigation in 48 hours, but we do within that time want to let that client know that we've received their report and be able to tell them what they can expect as far as next steps. If a client tells you they feel that there's an imminent risk to their safety, then we want to act immediately. So for example, a client may say, I can tell you about this now because the perpetrator is not in the building, but I know when they come back, you know, they're going to be looking for me. So I need you to help me in this situation right now. So that's what we would consider an emergency grievance. Doesn't have to be reported on the actual grievance form. It's about the sense of urgency. So if someone were to report something to you and tell you that they feel like there's an imminent risk to their safety, we want to make sure that you report that right away so that we can address that client's concern. If they report to us an allegation of sexual abuse from another facility where they were housed or while they were incarcerated, we only have 72 hours to then report that allegation to that institution. So again, this is just to help you understand the timelines that are associated and why it's important to respond immediately. If the alleged victim remains in our program after the allegation has been investigated, we will check on them to make sure that they feel safe and that there's no retaliation for a minimum of 90 days. And if they're in our program longer than that, then we can always extend that period. But we will check on them periodically for a minimum of 90 days. And each time someone monitors for retaliation is how we document it. That is recorded for audit purposes. So a couple things we have to keep in mind when it comes to PREA standards. The standards aren't just something that stands on its own merits. So when we're investigating, we're looking at Alvis policies and procedures. We're making sure that whether the zero tolerance policy has been violated, because again, allegations impact not only the individuals involved, but on the agency as well. So we want to make sure that we're being prompt in our response and that we're being proactive in our efforts to prevent sexual abuse and sexual harassment. We want to make sure that we correlate any violations of our code of ethics or rules of conduct, which also applies to volunteers and interns and contractors. So there's a lot of layers, even though the standards exist independently. When we investigate, we're looking at multiple threads that have to be tied together. So you guys are, to us, fresh pairs of eyes and ears. Sometimes people get laxed because, you know, you're in that environment every day and you start to not see things after a while. You guys may come in facilities and immediately something stands out and you're like, whoa, why is this like this? Or why is this whole area, you know, clients are hanging out, there's no cameras. So we want you to identify and question those things, because we want to minimize facility vulnerabilities. So we know as many cameras as we have, they can't cover every inch of our facilities. So we want you to immediately submit an IT ticket, for example, if you see that cameras aren't working in facilities. How would you know if a camera's not working? Well, at our security coverage desk, there are monitors that show all of the cameras. So if any of those sections that represents a camera is blank, so it's just blacked out, then that means either there's no camera or the camera's not working. So feel free, and I strongly encourage you to question stuff like that. If you see a bunch of black spots on the monitors, just ask, well, are these black spots cameras that aren't working, or are these spots where there potentially could be camera connections, but we don't have a camera? So one is very different from the other. So any malfunctions of our monitoring technology that you become aware of, please report it right away. Or any other vulnerability that you feel may exist, please reach out to the management in that facility or contact me with your questions or comments. So that's all the information I have for you today. Are there any questions or comments about anything that I've shared today? Okay, seeing none. Then enjoy your holiday weekend and welcome to Alvis. And thank you for choosing Alvis for your internship.
Thank you.
Thank you so
Thank you.
much, Ramona.
You're welcome.
Yeah, This is such an important part of the orientation, and so we really appreciate you taking the time. Thank you.
You're welcome. Enjoy your afternoon.
Alrighty, everyone. So that concludes all of our guest speakers today. And I hope that you gained some insight about Alvis as a whole, just regarding our orientation. I hope that this helped you get a better idea of what we do in a broader sense, apart from your own specific programs in which you were placed. I'm going to go to screen share one more time because I have one more item to share, and this is just some reminders. So thank you for attending. If you are taking the internship for college credit, we ask that you email me your hours monthly. This will likely change later in the summer because we are soon to launch a new website where you'll be able to input your hours directly into the website. So it's very exciting. But right now, as we stand, just at the end of every month, if you could email me the amount of hours that you interned, we like to have that for our files, and especially if you're tracking that for your own college program, that's useful for us to have as well. And also send headshots to me so that we can craft your Alvis ID badges. And so this will all be information that I include in the email after the orientation as well. But all of you will be getting a nice key fob where you'll be able to gain special access into the building, and it will also just list your name and have your photo so that you're identifiable as an Alvis team member. And so I ask that you send me the headshot either over email or you could do it over text. But like I said, I will also send that reminder as well. And finally, stay tuned for information about our summer intern appreciation celebration. So this will also occur virtually probably. We like to know ahead of time the dates for your finals weeks, just in case there are any conflicts, because it's really a time to celebrate you and all of the work that you've done. So we hope that everybody's able to attend that. And finally, you can follow us on social if you want to keep track of any updates that we're doing. We have a lot of cool things going on that get highlighted on social every day. And please contact me and reach out if you have any questions. Right here, my number, my office phone is listed, but you also all have my cell phone number, I believe. It's in my email signature. So feel free to reach out using that number as well. That's actually probably the easiest way to get a hold of me, either that or email. And otherwise, that was all I had to present today, but I will be on the call until the very end if any of you have any specific questions for me. I will end the recording right now.